questions, we move on to the next speech. Our next speaker is Dr. Dikshaladevi Pathmanathan. She has left us with curiosity. Her topic goes as pins, pricks and pink cells. Let's see what she has in store. While Dikshala gets ready with her presentation, I have an announcement to do. Please scan the QR code for CPD points and don't forget to sign the paper which is outside. It is, conveyed to me that some of you have forgotten to sign the paper. Put your signature there. In the ministry, they might check both the signature and the QR code. Thank you.
Good afternoon, everyone. I am Dr. Dikshaladevi Pathmanathan, Senior Registrar in Rheumatology and Rehabilitation, National Hospital of Sri Lanka. So today I am going to talk about pins, pricks and pink cells. Some of you might have an idea on what is the topic is. Let's see. So without getting delay, I would like to go into my presentation. So our patient is Mr. W, 49 years old, manual laborer from Polgasvita, was healthy until February 2025. Then initially he presented to the local hospital with severe generalized acute abdominal pain in early August 2025. The pain was associated with meals, which was increased in severity with the meals. There was no history of altered bowel habits or bleeding with defecation. It was spontaneously settled in one day and it was not further evaluated by that time. Then 4 days later, he developed bilateral asymmetrical pain and numbness in both upper limbs and lower limbs, right more than left, which was gradual onset, shooting in nature, worsening over the time, involving bilateral upper limb and lower limb asymmetrically. The severity was around 7 to 9 according to the pain scope. Pain increased with walking and relieved with rest and disturbed his sleep as well. He had associated arthralgia and joint swelling involving mainly large joints and some small joints of hands and feet. There was no early morning stiffness or associated axial symptoms. With that, he had a history of patchy erythematous, painless, non-itchy rash involving both lower limbs. It was vasculitic rash in pattern. He had constitutional symptoms also for past 6 months with loss of appetite and loss of weight. During that 6 months period, he lost around 20 kilos. There was no history of low-grade fever, evening pyrexia or past or contact history of tuberculosis. No respiratory symptoms like nasal crusting, hemoptysis, epistaxis, shortness of breath, or chest pain, orthopnea or paroxysmal nocturnal dyspnea. No urinary symptoms, no sinus involvement. No significant headache, seizures or blurred visions, no red eyes or Zika symptoms, no history suggestive of SLE or no history of needle prick injury, blood transfusion or high-risk behavior or drug abuse. Other than the recent history of abdominal pain, there was no other GI symptoms. He is a non-vegetarian, taking fish, meat and milk regularly, no family history of malignancy or other autoimmune diseases. In past medical history, he developed wheezing with persistent cough with diurnal variation since February 2025 and was diagnosed as a bronchial asthma and started on Foracort and Astelin inhalers at local hospital. Following that, his symptoms were well controlled. Past surgical history was not significant. Allergy history also not significant. He is a manual laborer, father of 4 children. So coming into the general examination of the patient, he is averagely built with the BMI of 23.45 kilograms per meter square, afebrile to touch, not pale or ictery, no oral ulcers or lymphadenopathy, no malar rashes or photosensitive rashes or vitiligo, no peripheral stigmata of infective endocarditis, no Raynaud's phenomenon, or no ankle edema. All the peripheral pulses were present. There was a non-blanching vascularity crash involving both lower limbs, which was started to peeling off while we examining the patient. Cardiovascular system, respiratory system examination and abdominal system examination were unremarkable. In neurological examination on the second day of admission, we found that in bilateral lower limbs there were no wasting or scar or nerve thickening or fasciculation. Tone was normal in both lower limbs. Power reduced in both limbs. In proximal muscles, 4 out of 5. And in distal muscles, 4 plus out of 5. And bilateral knee reflexes were preserved with mildly reduced ankle reflexes. There was glove and stocking type sensory loss. And there was a subtle bilateral foot drop also noted. Upper limbs were unremarkable. Cranial nerves were normal. Musculoskeletal and joint examination revealed tender joint count of 13 and swollen joint count of 4. Involved joint showed limited range of movements. So, if we see the timeline, in February 2025, he was treated as adult onset bronchial asthma-like symptoms, and while presenting to National Hospital, he had acute severe. While presenting to the local hospital, he had acute severe abdominal pain, and 4 days later he presented to NHSL with the asymmetrical peripheral numbness, and on the same admission he developed lower limb vascularity crash. So if we look into the investigation, his WBC count was high, 7.5, with the neutrophilic count of 40.4% and lymphocytic count of 7.2% with eosinophilic count of 48.8%. Hemoglobin was normal, platelet also was normal. Then blood picture showed severe eosinophilic picture with reactive eosinophils, but no abnormal cells noted. Serum ferritin also 510, which was slightly elevated. SPE showed acute chronic inflammatory pattern. Monoclonal bands were not detected. CRP by that time was 113, and after the treatment, which it became normal, and ESR also initially 30. Then if we go into the liver function test, AST more than ALT, which is 58 and 32 respectively, and ALP also 101. Total protein was normal with no reversal of albumin globulin ratio. Total bilirubin also normal. Renal functions, creatinine was normal, but UFR showed moderately feelful red blood cells and no proteinuria. UPCR was normal with the 0.19. Renal biopsy was not advised by the nephrology team during this admission. CPK 78, LDH was 358, TB screening was negative, blood and urine culture negative, procalcitonin was 0.23. Coagulation profile was normal, and chest X-ray showed no lung shadows. Ultrasound abdomen also was normal. NCCT KUB showed right-sided redundant and dilated ureter, likely to be congenital, no calculi. 2D echo was normal, no pulmonary hypertension, no evidence of infective endocarditis also. HRCT normal study. CT mesenteric angiogram was not done during the ward stay since the patient was asymptomatic. VDRL, retroviral screening, hepatitis BC all were negative. And nerve conduction study findings are consistent with mononeuritis multiplex involving left peroneal plus bilateral ulna more than median nerves. ANA was negative, rheumatoid factor also negative, but when we did the ANCA studies, PR3 ANCA was negative, but MPO ANCA was positive. This is the skin biopsy we have done, leukocytoclastic vasculitis affecting small vessels with some infiltration of eosinophils. So, we have treated the patient with IV methylprednisolone pulse, 1 gram daily, 3 doses given. Oral prednisolone also 60 milligram mani and slowly then tailed off. With the meantime, we have started the bone protection and oral bisphosphonates as well. And after that, he was started on IV cyclophosphamide 750 milligram, 2 weekly 3 doses and 3 weekly 3 doses. Then later on, he was started on MMF. So, current status, his vascularity crash was completely settled, eosinophilic count was gradually reduced, and latest report showed only 2% of eosinophils in full blood count. Latest inflammatory markers were ESR 8 and CRP was 6. His UFR showed no active sediment. There is a minimal residual weakness and numbness in both lower limbs. He continues his job without much interruptions, following our clinic routinely. So by this time, you know that what is the diagnosis. So this is eosinophilic granulomatosis with polyangiitis. So without delaying, we'll go into the introduction. So ANCA-associated vasculitis usually divided according to the clinical manifestations like granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. So in GP and MPA, genetic associations are more stronger than the clinical diagnosis. Then evidence of the distinct genetic background between the PR3 positivity and MPO3 positivity is coherent with the demographic, clinical, and prognostic data. So in GPA, MPO ANCA positivity and ANCA negative substance we are seeing. So usually ANCA negative substance are associated with eosinophilia and asthma, and MPO positivity is associated with the other system involvement. And the genetic differences between the two EGA subsets supports the ANCA-based dichotomy of the syndrome. ANCA positive disease usually displays the vasculitic features and closely related to the MPO ANCA positivity, whereas ANCA negative disease usually shows the high prevalence of eosinophilia and other respiratory system involvement as well. So future studies are more focusing on genotype and phenotype, and prognosis pharmacogenomics also likely to improve our understanding of ANCA-associated vasculitis. So ANCA positive EGPA, as I said, usually associated with the MPO ANCA positivity. ANCA negative EGPA usually associated with eosinophil and barrier-driven inflammation. Predominant organs involved in ANCA positive EGPA: kidney, peripheral nerves, skin, and alveolar capillaries. While in ANCA negativity, usually heart is involved. So as a basic screening, we have to do the ECG and echo in symptomatic patients. And in lungs also, infiltrates are common, and GI system also involved in ANCA negative EGPA. So relapse pattern is common with ANCA positive EGPA. Biomarker profile, in ANCA positive EGPA, we can see the MPO positivity with the lower eosinophilic counts, while in ANCA negative EGPA, we can see the ANCA negativity with the higher eosinophilic counts, and it usually associated with the interleukin 5. So that is the major pathway which, considering the pharmacotherapy, we are going to block the interleukin 5. And therapeutic emphasis, usually in ANCA positivity, B cells are involved. There is a dysregulation in B cells. So we use the rituximab plus or minus cyclophosphamide for the vasculitic phenotype. And in ANCA negative vasculitis, we use the interleukin 5 blockage, which is a mepolizumab, and interleukin 5 receptor blockage, which is a benralizumab. Prognostic concern, in ANCA positive EGPA, we have renal and vasculitic flares. In ANCA negative EGPA, we have cardiac involvement and fibrosis. So here again, you can see the differences, different clinical manifestations of ANCA negative and ANCA positive vasculitis. So anyhow, overlap between the endotypes are common. For else, usually cardiac involvement is more common in ANCA negative EGPA, but in an MPO positive EGPA also we have seen eosinophilic myocarditis, and in ANCA negative diseases also we have seen neuropathy. So such mixed patterns reflect converging biology, type 2 inflammation plus humoral autoimmunity. So in that case, we usually use the combined therapy. And we have to treat the vasculitis first with the rituximab and cyclophosphamide, and then we have to add the interleukin, anti-interleukin 5 or interleukin 5 receptor blockers. Cardiac involvement is the leading predictor of morbidity and mortality, particularly in ANCA negative EGPA. So baseline follow-up evaluation should include ECG and 2D echo, as I said earlier. Cardiac MRI is recommended in presence of symptoms, biomarker elevation or unexplained ECG, and should be periodically repeated even in clinically stable cases. So here you can appreciate the C-ANCA and P-ANCA. The differentiation from other ANCA-associated vasculitis. In GPA, we usually see the ENT involvement with necrotizing destructive lesions, and in lungs we can see the nodules, mass, cavities, and diffuse alveolar hemorrhage. In kidney we can see the necrosis and crescents, and heart rarely involved in GPA. ANCA association is more common with the PR3 positivity, and histology we can see the granulomatous inflammation with the vasculitis. In microscopic polyangiitis, typically lung and kidney involvement is there with the MPO positivity. In histology, there will be no granuloma and only vasculitis we can see. In EGPA, it usually associated with eosinophilia, and asthma is a predominant respiratory symptoms. ENT, usually we can see the allergic symptoms, not like the GPA. In here, destructive lesions are less common. And lungs, we can see the infiltrates and nodules. Diffuse alveolar hemorrhage is very rare. Kidneys occur less likely, but more common in the ANCA positive EGPA. And in heart, it usually often involved associated with the damage and higher mortality. ANCA usually MPO positivity, but detected only in about 40% of patients. In histology, we can see the granulomatous inflammation, usually accompanied by the eosinophils and eosinophilic vasculitis. So again here, this is the summary of systemic manifestations in EGPA. So again, EGPA usually the clinical manifestations overlap with the other ANCA-associated vasculitis and hypereosinophilic syndrome. And in EGPA, usually ANCA positivity usually associated with HLA and MPO positivity. In ANCA negativity, usually associated with the interleukin 5s. So if we consider the pathogenesis, MPO ANCA positivity usually, as I say in the previous slide, it usually associated with the HLA, but ANCA negative vasculitis usually associated with the interleukin 5 pathway, and but in common pathway also we can see the interleukin 5 eosinophil axis. So and here we can see the immune dysregulation in effector pathways in EGPA. Interleukin 33, interleukin 25 and T helper 3 cells are involved in both pathway in the basic. And then MPO ANCA positivity, we can see the high amount of IgG4 levels as well. With that, it can cause the B cell depletion and dysregulation. So in ANCA positivity, since it involves the B cell, we usually gives rituximab. So in ANCA negativity, since it involves the T helper cells too, and it came along the pathway of interleukin 5, the main modality of treatment is to block the interleukin 5 with the either interleukin 5, anti-interleukin 5 or interleukin 5 receptor blockade. So here again the same pathogenesis you can see. The examples of anti-interleukin 5 is mepolizumab and reslizumab, and interleukin 5 receptor blockade is benralizumab. So the key differential diagnosis, hypereosinophilic syndromes. In that we can see the persistent eosinophilia of more than 1.5 into 10 to the power 5 9 per liter with multi-organ involvement, typically without asthma or any ANCA positivity. In bone marrow evaluation and the genetic assays, we can see the FIP1L1 PDGFRA positivity in hypereosinophilic syndromes, where we can see the myeloproliferative variants. In IgG4 related disease, it can present with eosinophilia and elevated serum IgG4, but there will be no necrotizing vasculitis. Histopathology typically shows the storiform fibrosis and dense IgG4 plus plasma cell infiltrates. But in EGPA, the IgG4 elevation reflects the Th2 polarization rather than the true IgG4 related disease. And chronic eosinophilic pneumonia, we can see the pulmonary infiltrates and marked eosinophilia without systemic vasculitis or extrapulmonary involvement. And parasitic eosinophilia, we have to ask the travel history and exposure history, and we have to do the serologic testing for helminthic infections. And there are drug-induced eosinophilias or vasculitis as well, commonly associated with antiepileptics and antibiotics. So peractical diagnostic checklist, we have to confirm the adult onset asthma, and we have to check for the blood eosinophilia more than 1.0% into 10 to the power 5, 10 to the power 9 per liter, and exclude other infections or drug-related or non-neoplastic causes of eosinophilia. And we have to evaluate for vasculitic involvement like neuropathy, renal involvement, skin or pulmonary involvement. And we have to test for the ANCA positivity and interpret the IgG4 levels as well. When feasible, we have to obtain a biopsy from the relevant places, and a systemic stepwise diagnostic approach usually needed. So recommended diagnostic approaches, usually blood test, full blood count and IgE levels, flow cytometry and rheumatoid factor, complements levels, urinalysis we can see. In pulmonary involvement, we can see the baseline CT test, pulmonary function test, and BAL if indicated. In GI involvement, we can get an abdominal imaging, and in cardiac involvement, we can get an ECG, BNP, cardiac MRI or PET, but routine screening of asymptomatic patient is not recommended. So if we see the classification criteria of EGPA, as Madam said previously, there are different final classification criteria for different ANCA-associated vasculitis, but in here we will see the EGPA only. Maximum eosinophilic count should be more than 1, and obstructive airway disease, nasal polyps, and ANCA positivity, for which we are giving different points. Extravascular eosinophilic predominant inflammation, mononeuritis multiplex, and hematuria. So patient could be classified as having EGPA after excluding mimics of vasculitis and having small or medium vessel vasculitis with the cumulative score of 6 or more. And these EGPA criteria have sensitivity of 85% and specificity of 99%. So here, to assess the prognosis and stratification of the disease severity, we use the 5-factor score. The 5-factor score developed by the French Vasculitis Study Group and validated in EGPA remains the most practical tool for estimating the mortality and guiding the therapeutic intensity. So the 5-factor score includes 5 points: age more than 65 years, cardiac insufficiency, renal insufficiency, GI involvement, and absence of ENT symptoms. So if there is no factor present, we can put 0. If one factor is present, we can put 1. More than 2 factors present, we can put 2. So, and 5-factor score more than 1 identifies patient at increased risk of death or relapse, in whom we have to start the systemic immunosuppressants immediately with the glucocorticoid. And in the list, you can see the live or organ-threatening manifestation: alveolar hemorrhage, glomerulonephritis, and CNS vasculitis, mononeuritis multiplex, cardiac involvement, mesenteric ischemia, and limb or digit ischemia. Non-organ threatening manifestations are chronic sinusitis without bone involvement, asthma, mild systemic symptoms, uncomplicated cutaneous disease, mild inflammatory arthritis, myositis, or non-cavitating pulmonary nodules. So, in 2024 EULA algorithm, in the previous presentation, you may have seen the general management of the ANCA-associated vasculitis, but EGPA management is slightly different. So, if there is an organ or life-threatening manifestation, we usually start the cyclophosphamide or rituximab combined with the high dose of glucocorticoids. And if there is no organ life-threatening, we have to see whether it is a relapse or refractory. If it is no, we can start the glucocorticosteroids alone and gradually taper the glucocorticosteroids to individual target. And if there is a significant relapse or refractory disease is noted, we have to start the mepolizumab, which is not available unfortunately in our country. And as a maintenance of remission, after that we can switch to azathioprine, methotrexate, or we can continue the rituximab with the significant interval. And if there is a sustained remission, we can continue the individual glucocorticosteroids. So here, if we see the EULA recommendation for induction of remissions in new onset non-organ life-threatening or non-life-threatening EGPA, we recommend the glucocorticosteroids alone, which is 0.5 to 1 milligram per kg per day prednisolone equivalent, which is tapered over 6 to 12 months. If there is a relapse or refractory disease only, we usually combine the glucocorticosteroids with the mepolizumab, which is an anti-interleukin 5. So for the induction of remission, we usually, for the organ or life-threatening disease, we combine the high dose of glucocorticosteroids either with the Ritux or cyclophosphamide, as I said earlier. But the cyclophosphamide is preferred when the rapid cytoreduction is required, likely in glomerulonephritis or alveolar hemorrhage, whereas rituximab is favored in relapsing disease or when cyclophosphamides are contraindicated. Maintenance is usually achieved with the Ritux, azathioprine, methotrexate or MMF, depending on the tolerance or comorbidities. So this is again the summary. Considering the 5-factor score, we usually stratify the disease, and if there is a severe disease for the remission induction, again I am repeating this, with the intravenous pulse followed by high dose of oral glucocorticosteroids, cyclophosphamide or rituximab is indicated. For the remission maintenance, we usually give oral glucocorticosteroids and rituximab and or mepolizumab with other DMARDs. In non-severe cases with the 5-factor score 0, we usually give the glucocorticosteroids alone, and for the remission maintenance only we use the mepolizumab here. In relapsing disease, again we usually treat with the IV pulse initially followed by a high dose of oral glucocorticosteroids with cyclophosphamide or rituximab. In non-severe cases, we can use the glucocorticosteroids alone or glucocorticosteroids with the mepolizumab. So if we see the BSR 2025 algorithm, that is also says the same. Compared to the other ANCA-associated vasculitides, the evidence-based EGPA remains unlimited. Only 2 trials are mainly available for the EGPA, which is MIRA trial, which says mepolizumab gives a specific efficacy in treating EGPA compared to the placebo. And while Mandara trial proves, the trial which compared the benralizumab, which is a anti-interleukin 5 receptor blockade, and mepolizumab, which is an anti-interleukin 5. It compared both drugs and proved that benralizumab is non-inferior to the mepolizumab. So here you can see the MIRA trial. In mepolizumab, we usually give 300 milligrams subcutaneously every 4 weeks. So in here you can see there is a 87% of efficacy, and if we use the mepolizumab, the patient usually needs reduced dose of oral corticosteroids later. In Mandara trial, the conclusion is benralizumab is non-inferior to the mepolizumab for EGPA. So, if we consider the treatment, biologic therapy in EGPA targeting interleukin 5 axis has transformed the management. Unfortunately, none of the drugs are available in our country. Mepolizumab achieved significant glucocorticoid sparing effects in MIRA trial, and while benralizumab was non-inferior to the mepolizumab in Mandara trial. Reslizumab remains an alternative for selected patients, and in both MIRA and Mandara trials, they define the remission as BVAS score of 0 and prednisone use of less than 4 mg per day, establishing the standardized criteria for the relapse and glucocorticoid sparing evaluation. In airway predominant disease, interleukin 4 receptor alpha blockage usually used in upcountries, so which is a dupilumab, and it can improve the airway control, but in those patients we have to be aware of the ANCA positive phenotypes due to the reported vasculitic flares. An upstream alarmin blockade, which is a tezepelumab, is currently under investigation. Real world practice increasingly integrates biologic switching with interleukin 5 receptor alpha blockade and B cell directed therapy. So biologics should complement, not replace, the comprehensive monitoring and organ specific management. So here you can see the drug class we can use: glucocorticosteroid, cyclophosphamide, azathioprine, methotrexate, MMF, IVIG, rituximab, mainly in ANCA positive EGPA with the vasculitic phenotype, and refractory cases also we can use. In mepolizumab, usually relapsing or refractory EGPA, steroid sparing, as a steroid sparing we can use. In benralizumab also, according to the Mandara trial, considered as which is non-inferior to the mepolizumab. And this is common for both ANCA positive vasculitis in other ANCA associated vasculitis as well. Rituximab preferred in children and adolescents, premenopausal women and men concerned about their fertility, and frail older adults. Glucocorticoid sparing especially important in some patients. So in those cases also we can use the Ritux. And relapsing disease and PR3 ANCA disease like GPA, OMPA also we can use the Ritux. And cyclophosphamide preferred in rituximab difficult to access severe glomerulonephritis. So usual dose of Ritux is 375 mg per meter squared per week for 4 weeks, or 1 gram on days on 1 and 15, but usually we prefer the first. Then the other management, we have to consider the PJP prophylaxis, bone health, mental health, sleep, and blood sugar levels. So in here we can see the trials which were supports the ANCA associated vasculitis, both GPA, granulomatosis polyangiitis, MPA, and some are related to the management of EGPA as well. So if we see the main Ritson's trial, which was compared the rituximab versus azathioprine, and rituximab trial also rituximab versus azathioprine, and RAVE trial mainly compared the rituximab versus the oral cyclophosphamide. So this is again the summary of the different trials. So this is the RAVE trial, rituximab versus cyclophosphamide for ANCA associated vasculitis, which says as a conclusion, rituximab therapy was non-inferior to the daily cyclophosphamide treatment for induction of remission in severe ANCA associated vasculitis, and may be superior in relapsing disease. So how to maintain a remission? We usually use the rituximab 500 mg 2 weekly interval at complete remission, and then 500 mg with 6 monthly intervals. And if we use the azathioprine 1.5 to 2 mg per kg per day at complete remission until 1 year after the diagnosis, then we decrease by 25 mg every 3 monthly. MMF 2 grams per day, divided doses at complete remission for 2 years. Then this is the Registrar trial, which explains the which conducted to see the rituximab and azathioprine efficacy. Then as a conclusion, we can see the result as following the induction of remission with the rituximab, a fixed interval repeat dose of rituximab was superior to the azathioprine. So nowadays, to maintain the remission, we mostly use the rituximab. Then superiority of the rituximab, rituximab was significantly better than the azathioprine and preventing relapses. So the factors which increase the relapse risk, usually baseline factors, diagnosis of GPA. This is common for the GPA, MPA and EGPA all. And PR3 ANCA subgroup, high serum creatinine levels, more extensive disease, ENT disease. And factors after the diagnosis, history of relapse, ANCA positivity at the end of induction, and rise in ANCA titers during the disease course. And treatment factors, lower cyclophosphamide exposure, immunosuppressive withdrawals, and glucocorticoid withdrawals. So this is again the summary of ANCA positive EGPA, ANCA negative EGPA, airway dominant EGPA, and refractory or mixed phenotype. So the preferred therapeutic targets in ANCA positive EGPA, we usually use the rituximab. With that, we can use the interleukin 5 blockers as well. And in ANCA negative cases, we mainly use the interleukin 5 and interleukin 5 receptor blockade because it usually involves that pathway. And in airway dominant asthma, we usually use the interleukin 4 receptor blockade, which is dupilumab, and interleukin 5 blockage also will be helpful. In refractory disease, nowadays evolving clinical trials are going on to think of JAK inhibitors. So disease monitoring, regular visits with the rheumatologist and other specialists on your team, nephrology, pulmonology, ENT, neurology, infectious disease. Routine lab test also we have to do, and monitor for and treating other infections, vaccination, monitor for hypogammaglobulinemia. So if we see the emerging treatments, as I said, interleukin 5 pathway is the main pathway involved in EGPA. So mepolizumab, benralizumab are used, and this shows the firmly established connection of interleukin 5 eosinophilic axis is the cornerstone of the EGPA pathogenesis. So this is again the pathogenesis of EGPA, which involves the interleukin 5 axis, while in airway predominant disease, interleukin 4 or interleukin 13 blockage is mainly involved. So interleukin 4 receptor blockade, which is dupilumab, also under the trials. So in future, B cell, still the trials are going on to check for the humoral immunity and B cell dysregulatory pathway, which is anti-CD38. Daratumumab also will come under the list. So this is again the different biologics. So take home messages, EGPA comprises 2 major endotypes, ANCA positive and ANCA negative types, with the distinct clinical manifestations and risk. Mepolizumab and benralizumab are now approved biologic for EGPA and supporting the steroid sparing management. The other biologics are still under trial. ANCA positive disease often requires B cell directed therapy for vasculitis control. And baseline and interval cardiac evaluation, especially in ANCA negative subsets, are essential. Dupilumab may benefit airway dominant disease but require vigilance for the vasculitic flare. Remission should be defined as using BVAS and steroid dose thresholds. Ongoing monitoring of eosinophil counts and organ specific imaging remains central to the management. So finally, I would like to thank the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka, and our Madam, Dr. Monica De Silva, Consultant Rheumatologist, and Ward 44 medical team, and our patient, Mr. W. So these are my references. Thank you.